Good afternoon, everyone. Before I begin, I would like to thank the organizers, Ravindran sir, Dr. Jibin, Fijad, and rest of the team for inviting me here. So the topic given to me is radial head fractures: fix, excise, or replace. Before we go into the topic, let's see this case. So this is a 30-year-old male, a doctor who is a very very much interested into badminton, and he had this injury 10 days back, and he was advised surgery elsewhere. What would you like to do? So he came with a slab. Any residents? What do you like to do? Fix, excise, or replace? He was on a slab. It's 10 days. Yes, so you need to look for the range of motion. So that's perfect. So we didn't do any of that. We just went with conservative management. And you can see he's a guy in red. He's smashing the shuttle all around the park in 4 months' time. So we just took off the plaster and mobilized him pretty early. And not sure if he had undergone the knife as per the advice, how many trophies he would have got. So this is the situation. Okay. So it is not just fix, excise, or replace. There is a big role for conservative management as well. So when we go down to the history, in 1954 Mason said, when in doubt, resect. So this was his first 100 cases, and he made that observation. But in 1968, Johnston said, reviewing his 100 cases, when in doubt, conserve. So there's a paradigm shift between these ideologies. And again, this is the classification that you need to know. So we have type 1, which is undisplaced. Type 2 is displaced more than 2 millimeter, angulated. Sometimes you get mechanical block, as you said. That is one thing that we need to check. Type 3 is comminuted, displaced, and type 4 is associated with dislocations. So when to conserve? We should always do the clinical evaluation. So go back to the basics. We should check for the integrity of MCL. I think sir showed many videos on to check for the instabilities, and the interosseous ligament is important because we shouldn't miss SX low-prosty injuries, and distal radial joint is very important. So when you're doing the range, we should look for crepitus and mechanical block. So most of the times it's very difficult to examine this because in an acute scenario the patient will have severe pain. So what we can do is you can aspirate this hematoma and inject a local and then range the elbow and see if there is a mechanical block. And if there is no mechanical block, you can go ahead and you can start early range of movement within 3 to 7 days once the acute phase is over. And the indications are usually for the type 1 and type 2 fractures without mechanical block, and outcomes are relatively good. But if you prolong the immobilization, then your biggest enemy is the stiffness. So this was a case, a 50-year-old male who had a history of fall from stairs. He was not willing for surgery due to some personal reasons, and we did a close reduction, and you can see there is a big chunk of radial head there. And he came back 2 months later due to ongoing pain on the ulnar region. It's not, and his range of movement was pretty good when we took him up for fixation for ulnar. There was no mechanical block, so it went on to unite well, and we just managed the radial head conservatively. So this was 4 years follow-up, and he is having reasonable function. So radial head fractures without mechanical block, you can leave it. So when to fix? So that's the next question. So all fractures with these mechanical blocks, or when it is fixable, that is when you have around 3 or less than 3 fragments, and in the presence of other complex injuries, you can fix this. And all these details have been dealt by Dr. Ajay and Dr. Sibyl. You have to pronate the forearm to get the posterior interosseous nerve away from the field when you are approaching from the lateral, from the Kaplan approach especially. And it's always good to stay the equator of the lateral epicondyle. Why? Because below the equator is where you get the LUCL, the lateral ulnar collateral, which is very important for the stability. So that gets damaged in the Cocker's approach. And the safe zone for fixing or putting up an implant is between the zone from the radial styloid and the Lister's tubercle. So that is the area which is non-articulous, and you can safely implant there. So this is again the Kaplan approach. You can see it goes between ECRB and EDC. And so here the risk of injuring the pin is slightly more, but LUCL is safe. And in Cocker's approach, you get the interval between Anconius and ECU. Here the chance of injuring the LUCL is high, but the risk for pin is less. And the problem is, again, the approach is below the equator. So once you get it below the equator, there's a chance that you can destabilize the elbow. So there's a compromise between that. That is the EDC split approach. Sibin sir has already mentioned that. So it's a, it mitigates the risk between the pin, injury to the pin as well as the LUCL. And staying anterior to the equator always is safe. So this was another case, a 30-year-old male military officer. He had a fall from height during one of his military exercises, and you can see it's a Monteja kind of fracture, and radial head is actually lying posteriorly. So we exposed, got the radial head back in place with 2 screws here, and we can see the radial head is moving in one piece. So this was another case, the 50-year-old female who had a slip and fall. She again underwent a similar kind of fixation, and she has a good range of movement. So CT scan is pretty important to analyze how the fragment is rotating and whether it causes and it helps in the planning as well. So never miss out on a CT. And this was another interesting case, a 27-year-old nurse who had a slip and fall from stairs. And you can see it was a dislocated elbow. And post dislocation, do you notice something? Anything interesting? Yes. So the radial head is lying somewhere here. It's not in its place. So that is again confirmed with the CT. So it's important to get a CT scan post reduction. And she again had, considering her age, we thought of salvaging the head. We got it assembled on table and then stabilized with a plate as well. And this was the 3 months post-op. And she, being a nurse, as all nurses would do, she flew to UK. So we did not have a follow-up. We tried contacting her. And this was another case, a 22-year-old male who had a collision bike against a post, and you can see the radial head is shattered into 2 pieces, 2 or more. Again, we assembled it back and got it supported with a plate there. He had implant issues, so it got removed after 1 year, and you can see a few retained implants, and he decided to give us this function. So this is after 6 years follow-up. He is having relatively good function, and he's pretty happy. So now when to excise? So there can be fragment excision or total head excision. So when you want to consider a fragment excision, it's mainly indicated when the fragments is less than 25% of the surface. And even if you, at times, even small fragment excisions can lead to instability. So you need to be really careful when you excise it. And complete radial head excision is mainly for low demand sedentary patients or in a delayed setting. It's a salvage procedure provided there is no instability. So that is the highlight. If you have an unstable elbow and you excise the radial head, you are inviting disaster. So yeah, this was one case who presented to us delayed 7 months post elbow dislocation. And we can see her pronation and supination is restriction, and she has a restriction of elbow flexion as well. So there is a big mechanical block there, and she has difficulty in having food because she has to strain a lot to when she's having food. So this was one case where we decided to excise, and there was no other instability. on examination, and you can see the range of movement, the supination and pronation has improved 7 months post excision, and her range of and flexion has also improved really well, so that she can carry on her activities of daily living. So what happens when you excise the radial head? So uh, the entire transmission, the load transmission now is concentrated on the ulnohumeral component. So that can lead to osteoarthritis. So, but studies have shown that despite this, if there is no instability, the patients will get satisfactory results in more than 90% of the cases. And osteoarthritis changes are uniformly present, but typically are not associated with functional impairment. So that is what and it is, we saw one case. She came for some other issues, and we took her elbow x-ray, and she had an excision of the radial head 30 years back, but her function was reasonably good despite developing a ulnohumeral osteoarthritis. So this is the usual natural history. So never ever forget to examine for a sexual opportunity injury or a torn ulnar collateral ligament. So in these scenarios, if you excise, it will be an issue. But there are studies which shows that if you repair the MCL and the medial capsule, then you can get away with a radial head excision. So the ligament integrity is very, very important, and there are various techniques, as Anil sir has already, the push-pull technique, the radial axial intraosseous load. So all these techniques can give you a clue regarding this instability. So when to replace? When it is not reconstructable, elderly, low demand patients. And studies have shown if you try to fix that with screws or plates, it's not going to work. It is the patient will invariably have poor results. So in that situation, you go ahead, replace it. Prosthesis stabilizes the elbow as the ligament heals. So prosthesis maintains the length till the ligament heals. So this was one case, 75-year-old female, fall at home, low demand, shattered radial head, and this is her function. She has FFD, but she is pretty much happy with the result she got. So to take home, this is an algorithm from Rockwood book. So you can see here, if it is an undisplaced fracture, you can go ahead and do early range of movement at even 7 to 10 days. And if it is displaced and there is no block to motion, then you can again go for conservative management. But if there is a block to motion, crepitus or concomitant injury requiring treatment, then you have to consider whether the fragment is small and unrepairable. So if it is a small and unrepairable, you just excise it. But if it is a repairable fragment, you can fix it. And in the case of large unrepairable fragments and the ligaments are intact, then you can go ahead for an excision. But if the ligaments are ruptured, just go ahead and do a radial head arthroplasty. So to take home, when in doubt, treat conservatively. You are not burning any bridges by treating it. You still have time to come back and deal with it. Thank you.